Okay, guys, inflammatory and structural heart disorders. Here we go. Inflammatory heart disorders. The first thing we're going to talk about is rheumatic fever, go into infective endocarditis, myocarditis, and pericarditis. What we're talking about is the different layers of cardiac tissue, and which can lead to damage to heart valves, heart muscle, and pericardial lining. Okay, rheumatic heart disease. The biggest thing I want you to remember about rheumatic heart disease, it's due to strep throat and a lack of finishing your antibiotics. Everybody knows that you have antibiotics in your cupboards that you have not finished, and you start feeling better and you don't finish them. Okay, well, that can be a start of your rheumatic fever problem. Peak incidence between 5 and 15. And the biggest thing to realize with this is with a 5-year-old, it's not necessarily, bad parent, because I can tell you I'm a bad parent because I know there's been times that my kids didn't finish all their antibiotics. But what happens? The 5-year-olds complain about how sick they are. They're not eating. They're not drinking. You take them to the doctor. They say, oh, you have strep throat. Next thing you know, you come back home. You give them that nasty medication. Your kid starts feeling better, and then lo and behold, you forget to keep them on that antibiotic. Same thing with a 15-year-old. Your 15-year-old's feeling sick. Oh, I can't eat, I can't drink, miserable. Well, I should say more miserable than normal. And then you go take them to the doctor. They give you antibiotics. You take them home. I feel sick. Oh, it hurts. It hurts. They start taking it. They start feeling better. And what happens? You say, hey, did you take that antibiotic that you're supposed to take? They're like, yeah, Mom, I took it. Lies. They're all lies. What could happen because of that lying and them not finishing that antibiotic? Next thing you know, you turn around and you have rheumatic fever. Rheumatic fever is indicative of having valve problems later on in life. Okay, it might not be today, it might not be tomorrow, but in life. So anybody that's had rheumatic fever, we kind of put them on the road of, well, just in case you do have some valve issues, we're going to put you on prophylaxis. When you go to the dentist, we're going to give you antibiotics, but we'll go to that on the next slide. Damages heart valves and a major cause of mitral and aortic valve disorders. Okay, and you can see all the different things that can happen with rheumatic fever. You have valvulitis, pericarditis. You can hear a rub, rub. Okay, myocarditis, which we'll be talking about later, urethrum margitum, and it's these red spots all over the body, feel like crap. Okay, is everything that can happen with this. And here's that rash that they get. Okay, so it can cause problems in all 3 layers of the heart tissue. Ashkoff bodies are granulocytic inflammation, okay, with rheumatic carditis. Endocardial inflammation leads to swelling and vegetation lesions on valves. Valve leaflets can become rigid. They can cause stenosis and regurgitation. Remember, the regurgitation can be in the aortic or mitral valve, but generally it is in the mitral valve. Diagnostics, what's the first thing you're going to ask? Gee, have you had a sore throat in the last couple of months? Did you finish all your antibiotics? Okay, we're going to start asking questions like that. We're also going to do a CBC, an ESR, and a CRP. We're going to see if there's an inflammatory response in the body. An ASO titer actually measures the antibodies against the strep. Okay, and then we're going to do a throat culture. Did that strep come from the throat? I mean, it's kind of like, I don't know, we just want to make sure. Okay, medications, antibiotics, penicillin's first, the first choice. We also can give them amycin and clindamycin if they do have a penicillin allergy. Remember, check your allergies before you give the medications. Okay, pain control is generally NSAIDs because we want to relieve the inflammatory process. Okay, and we can give them some steroids. Okay, and it can help relieve the inflammation. Okay, patient education. Watch out for sore throats, right? Okay, and whenever go seek some appropriate treatment. And when you get that appropriate treatment, make sure you finish the antibiotics. Okay. Also, we're going to do antibiotic prophylaxis. So if they did have rheumatic fever, we're going to make sure that before they go into a dentist or get a colonoscopy or anything that's going to have bacteria enter their vascular system, we're going to make sure they have antibiotics. Okay, because one thing we don't want to do is they have to go and maybe get a tooth pulled for braces. We don't want that bacteria to get into the bloodstream and go right into the heart and cause issues with the heart. Okay, preventative dental and good oral hygiene. Guys, I hate to say it, but mouths are nasty. All kinds of bacteria. Bacteria grow at least 5 times a day in the mouth. So we should make sure that not only our patients are doing good oral hygiene at home, but when they come to the hospital, a lot of times, I don't know how many times I've gone into a room, patients have been there for 2 days, and there's cellophane still on their toothbrush. Gross, gross, gross. Okay? Get those teeth brushed. I know for a lot of people, we just look at it for, breakfast and dinner, after dinner. But let's think about it. Okay? When you have a mouthful of bacteria, where's that bacteria going to go? It's just going to go down into the lungs. Okay, it's just going to march right down in the lungs, and we're going to have a hospital-acquired pneumonia. Let's stop it. Brush, brush, brush. Okay, good dental care. Pericarditis. It can be an infection. A lot of times, though, it's an injury to the myocardial. Okay, neoplasm, radiation trauma. Okay, connective autoimmune disorders, connective tissue disease, and post-op surgery. Okay, so what it is, it's an inflammation. Not an infection, it's an inflammation. It can be sharp, okay, onset, which means that the inflammation is having fluid into your pericardium. Remember what a pericardium is. It's the sac around the heart. So when you have excess fluid surrounding the heart, okay, it's going to be a little bit painful, okay. Pain is aggravated, but every time they breathe, okay, when they change position, it hurts. Pain is relieved by sitting up forward, and I don't know where you're going to see it, but you're going to see that somewhere, okay? Going to see pain relieved by sitting forward, pericardial friction rub, get it like two, I think of like almost like a balloon rubbing together, okay? You're going to hear a little bit of a rub and a low-grade fever. Now, this can be just injury. You're driving in your car, you have an accident, your chest goes up against your steering wheel, and your heart goes into an inflammatory response. Kind of like I know a lot of times we think of inflammatory response with infection, but think of your sprained ankle. You sprain your ankle, you have an inflammatory response on that ankle. Fluid filled, it swells. This is what's going on with the heart also. Don't think bacteria, think injury. So what are we going to do with this injury? Well, first we're going to diagnose it. And somebody comes in and say, oh, I got chest pain, so what are we going to do? EKG, CBC, cardiac enzymes, and see what's going on. Now, what's cool about the EKG is the EKG is going to show that there's diffuse ST segments. If you look, the ST segments are elevated, but there's no real big QRSs, are there? Okay, that's showing that what's happening really is that when you have that EKG, it has to go, those electric impulses that the EKG senses has to go through all that fluid. And so that's going to be a lot more diffuse. Okay, so it's not going to be as high. The amplitude is going to be lower. So, but you can see, look at all those. And if you just look at that, you're going to see, oh, wow, they're having an STEMI, right? Not in this case. Okay, echocardiogram and chest x-ray we're also going to use. Okay, for non-complicated treatment, we're going to use acetaminophen for fever and NSAIDs for inflammation. You can also use steroids. What kind of steroids are we going to use if they're in the hospital? You got it, Solumental or methylprednisolone. Okay, and if they're going home, we'll just use prednisone. Now, if it's complicated, and when we talk about complicated, there's excess fluid, so much fluid that we have to get the heart off. And in a couple slides, we'll be talking about cardiac tamponade, okay? The heart's actually getting smothered. So we can do a pericarditis, which I'm sure you watched on Grey's Anatomy. I've yet to see an episode of Grey's Anatomy. Maybe that's my next venture. But, you know, when they take a 2 syringe with a huge needle and they just sit there and like, oh, they're in cardiac tamponade, and they take that 2 and throw it into their chest and they draw back lymph and blood and pus. Okay. So it's not that dramatic. Generally we do it under ultrasound, so that we can see exactly where we're hitting with the pericardial sac. Dr. Gray Dreamy or Dreamy Gray, I don't know his name. I don't know. Anyway, he generally doesn't use ultrasound, I'm sure, but you know, that's TV. What we're talking about is an ultrasound. What's really cool though is if you look up at some YouTube videos, they can actually do a pericardiocentesis with that TUMI, and they can, just by going into near the heart, they can watch that EKG and they know when they hit the pericardial sac. Kind of cool. Pericardial window is another what we can use if the heart is going into cardiac tamponade. It's an open procedure where we take part of that pericardium out and insert a drain so that it's able to drain. Okay, complications of pericardial effusion, abnormal collection of blood between the pericardial layers. There could be pus, blood, serum, lymph, or a combination of everything. Okay, it can come on gradual. You know, maybe it is an injury. Maybe it could be radiation, and the radiation injury would be, you know, a lot slower than hitting your chest against a wheel of your steering wheel. Okay, cardiac tamponade is a complication that is emergent. Okay, so if you're listening to your patient, they have pericarditis, and you listen to them at 7 a.m. and you hear lub dub, lub dub, lub dub, lub dub, everything's great. You go back in there at 9 o'clock and you hear lub dub, lub dub, lub dub, lub dub, and you're like, I wonder if that's a little bit less. And then you go back at 10, you hear lub dub, lub dub. Patient's a little anxious, maybe not anxious, maybe they're a little blue. They're not getting where they need to go. Okay, the blood's not getting where it needs to go. What's happening is you have that pericardial sac and it's filling with fluid. Now there's only so much fluid that pericardial sac can actually hold. So what it's going to start doing is pressing against that heart. Okay, because that fluid has nowhere to go. It's like a big old balloon, and there's nowhere else for that to go. I wouldn't even say balloon, because a balloon can pop in a pericardial sac. We don't want it to pop. In fact, I've never heard it pop. I've just heard it, you know, what would you say? It just suffocates the heart. It might pop. Anyway, so you have all that fluid surrounding that heart, the myocardium, and it's pushing down, and eventually it's going to suffocate it. So it's the myocardium, your ventricles, your atriums aren't able to move like it should. And that's what's causing all the problems. Okay, so what we do is we go in there and we remove that blood, the lymph, the inflammation, okay, so that the heart can move again. You can have that because of pericarditis. You can have it because of cardiac surgery. Okay, maybe you just got out from a cabbage. So we're going to go in, you come back to ICU, and then we start noticing that we're having a harder time listening to your heart. What we don't want to do is wait until we get a Doppler, till we need a Doppler to get your heart sounds. Okay, we know what's happening. We know the disease process. Don't wait too long. Because quite honestly, you can sit there and you can do chest compressions on a patient in cardiac tamponade, and it's not going to do any good. Okay, because the heart has nowhere to go. You know, the myocardial tissue has nowhere to go. So what we're going to look for also is heart failure. Okay, Pulsus Paradoxus, which is on the next one, muffled heart sounds, dyspnea, tachypnea, tachycardia, narrowed pulse pressure, hypotension, and distended neck veins. So Pulsus Paradoxus is a large decrease in systolic blood pressure and pulse wave amplitude during inspiration. The normal is less than 10. So we're talking it's a greater than 10. Okay, that point in time. I'm not going to test you on this. Okay, it's a sign and symptom of cardiac tamponade. Generally, you could see this in ICU, but I really find it would be hard to find it if, up on the floor. Okay, you really have to be watching a patient to be able to see this. And I could be wrong, but Lord knows I can be wrong. But anyway, nursing management, early identification is key. Okay. Look, remember, we like to take people to surgery when we feel like taking them. We don't want to have to rush them down, or we don't have to perform anything in the room. Assess chest pain. How are they feeling? Okay. Heart sounds, position for comfort. A lot of times they're better. Well, I'd say 99% they're better the higher they are. Okay. Or if they have to move forward, sitting on that bed table like a COPD. Heat cold therapy helps with the inflammation. Encourage deep breathing. It hurts. They're not going to want to deep breathe, but the last thing we want is for them to have pneumonia and pericarditis. And O2 is needed. Now, let me go back to this auscultate heart sounds. We had a nurse and she sucked. I mean, she wasn't very good. And she had a patient with pericarditis. Not once did she assess that patient heart sounds for the 12 hours of that shift. Okay, she ultimately got fired because of it. Patient was fine, but the problem is it's pericarditis. You can't just sit there and not listen to heart sounds. Okay, so that's very important. Okay, myocarditis, that's the inflammation of the heart muscle. So every time that heart muscle beats, it hurts. Okay, results in an infection or immune response to radiation. A lot of times it's just viral. Okay, it could be bacterial, but normally it's viral. And immunosuppressed patients, of course, are a higher risk. Your cancer patients, your lupus patients, your patients with HIV and AIDS, your patients that are on that have COPD, that are on high doses of steroids. We have patients that have leprosy and they're on high doses, okay, or even your transplant patients, okay. So let's look at everybody that could possibly be at a high risk or that are immunocompromised. Okay, we're going to get EKG, cardiac markers, endomyocardial biopsy. I would suggest that we do that only if there is no other reasons, like we're giving them antibiotics and it's not working. Okay, then we'll go in and get a biopsy. Okay, but it's awfully invasive just going in and getting a biopsy from a heart muscle. Okay, so it's almost like a last resort. We're going to do antibiotics. We're going to do broad spectrum. When we talk about broad spectrum, we're talking about perpicillin, or otherwise known as Zosyn. Okay, that's considered broad spectrum. If they are possibly, from a nursing home, or they're from HD, we're going to assume that MRSA might play a role. So we'll do the Zosyn along with the vancomycin, just cover our bases. Okay, heart failure treatment if necessary, which we just talked about. Bed rest. This is probably the only time, one of the few times you're going to hear me say that bed rest is great for this patient. Every time they move, they're going to cause the need for more oxygen to that heart muscle. We want them to be nice and calm, and so that they do not need an increase in oxygen to the heart muscle. Okay, we're going to decrease the workload of the heart. Ineffective endocarditis is an interesting item, disease process. So its greatest risk factor is from prior damage to the leaves or valves of the heart, or valve prosthesis. It can happen with increased risk of aging. Okay, now on my side it says IV drug use and invasive hemodynamic monitoring, so like an ART line, okay, an ICU, and renal dialysis or other high risk factors. So basically what we're looking is for a bacterial highway to the heart. Okay, so anytime that a patient's opened up and, you know, the vascular system is open to bacteria, we are looking for a risk for infective myocarditis. Of course, I hate to generalize, but our IV drug user friends are not known to be the most sanitary with their needles. So of course they have a higher risk due to that. Okay, but there's other factors. It could be a patient that had a cabbage. Okay, it could be an OB patient. Okay, that during surgery they had bacteria introduced into their system. It can also, strange story. It could be. I love the show ER. I don't know who. I guess if you're old, well, I'm not old, but I love ER. Anyway, it was interesting because I was watching it on Thursday night. They have it, streaming all the time. But anyway, on Thursday night, and this girl kept on coming that came in, and she was in a collapse. There was some kind of concert and something collapsed. Anyway, she was having a hard time breathing and blah, blah, blah. And Dr. Carter was trying to figure out what was going on because everybody was pushing her aside. Anyway, he looked at her fingers, which we're going to learn, looked at her fingers, asked a couple of questions and put her into a room and said, have you had rheumatic fever? Have you had this? Have you had that? And she's like, no, I haven't had any of that. And they turned around and they were like, well, something's causing this. And have you had surgery? Haven't had surgery. And she's like, what are you talking about? And he said, well, I think you have an infective myocarditis. It's an inflammatory response to your endocardium. She goes, no, I haven't had any surgery. And then her friend looks at her, well, you did have. And here it turns out that she had a piercing done in a place and it got infected. And because it got infected, it got into her bloodstream and that bacteria went to her heart. There was something else somebody messaged me that a gentleman had an abscess tooth. And through that abscess tooth, he ended up with an infective myocarditis. So I can't say it's popular, problem to have because it's not, we do run into it. Last 8 weeks, we had a gentleman with a kidney transplant that ended up with ineffective myocarditis. Okay, so think about a superhighway to your heart. Bacteria having a superhighway to your heart. Okay, manifestations, fever, flu-like symptoms, cough, joint pain, heart murmurs. Okay, you can have petechiae, splinter hemorrhages, and these are the splinter hemorrhages. It's underneath your nails. Osler nodes, they're painful nodes on the palms, and genuine lesions. Okay, these are all signs and symptoms of ineffective myocarditis. Roth spots are actually on the next slide, and there's the spots on your eyes. Okay, generally we won't see that. That would be for them to, a doctor to go and look for those. Okay, diagnostics, dental, surgical, gynecological, cardiac cath, invascular access, IVDA, renal dialysis, or infections. Okay, like I said, think superhighway. Now, because we're talking superhighway, we're talking about the endocardium. Okay, our diagnostics, blood cultures, serum testing, CBC, ESR, that's our SED rate, chest x-ray and echocardiogram are all diagnostics that we're going to use. But quite honestly, if you have those other signs and symptoms, we really don't need these diagnostics too much because we know what you have. Okay, treatment. Prevention of your high-risk patients. So your patient that is a dialysis patient, let's make sure prophylactically, okay, that we don't give them any added bacteria, okay. Now, there's a problem. So the only way to treat this is antibiotics, okay, specific to the organism. Typically we use penicillin, but it's long-term IV treatment for 6 to 8 weeks. Long term. IV. It's not IV, go to PO. It's IV. Okay? We could use vancomycin and rifampin and gentamicin, okay? But our go-to is typically penicillin. Now, why is that a problem? Well, think about it. Okay, long-term IV therapy. So generally when we're talking about long-term IV therapy, we're talking about PICC lines. And you're like, well, that's not a problem. Just get Ethel to go throw a PICC line in and give them some IV therapy. Home health can go home. They can show them how to hang their, the medication, and all is good. But let's look back. What are some of these folks? What are they known for? Well, our IV drug users, wouldn't they like to go home with a PICC line? I bet they would. Okay, and what do you think? Do you think they're going to use that PICC line just for the medication? Now, we could have them come into the hospital every day and get a new IV kit or start and get antibiotics, but that's kind of rough too. A lot of their veins are shot. And to get them, well, to be compliant to come in is one thing, but for them to come in and use the same vein, we might just run out of space. Now, we can't make them stay in the hospital, and who's going to pay for that? Hate to say payment word, but who's going to pay for that? So what they've done is they've put them in nursing homes. But let's face it, if you're an IV drug user, I don't think you're going to think that a nursing home is a cool place to be. So here lies the predicament. Now, up in Minnesota, there was a lawsuit that some hospital had a patient that was an IV drug user, had an infective myocarditis, and she signed a contract saying that she would not use her PICC line for any IV drug use. Well, guess what? The patient died due to an overdose, and the family was suing the hospital because they shouldn't have gave her that PICC line to help with that infective myocarditis. You see the ethical problems with this. So it's interesting to have to work through all this muckety muck. Okay, not saying that all of the patients that come in with ineffective myocarditis are IV drug users, but we have to be careful if that's the reason they got it. Okay, surgery could happen because of valvular regurgitation that causes heart failure. Okay, nursing management, preventative cares. Avoidance of infection, good oral hygiene, planning activities to avoid excess fatigue, and recognize the heart failure symptoms. We're going to make sure that our patients with prosthetic valves are using antibiotic therapy before they go into get their tooth pulled, or they go in and get their colonoscopy. Congenital heart disease with repairs, okay? Anything that's going to have any kind of problems with the heart, have any kind of vegetation, any kind of tissue scarring, okay? We're going to be very careful with the prophylactics. We're going to make sure they get their antibiotics, and any dental procedures, respiratory procedures, GI or GU. Remember, superhighways to the heart. Okay, valvular disease interferes with blood flow to and from the heart, may be required for other conditions such as ineffective myocarditis, rheumatic fever, MI. We also have problems with stenosis. Valve opening narrows, become rigid, so not enough blood gets through there, and regurgitation, which it goes into like the left ventricle, but then backflows into the left ventricle, is all considered part of valvular disease. Okay, what are we going to do? Well, quite honestly, when it first starts, unless they have symptoms, we're not going to do anything. Okay, so that murmur that you might hear because of valvular disease, we're not necessarily going to do anything, not until they show symptoms: fatigue, weakness, dyspnea on exertion, orthopnea, angina, palpitations, syncope, worsening. Okay, they start having jugular vein distension, ascites, peripheral edema. We're really looking for that heart failure. Okay, heart sounds, additional heart sounds, and the murmurs could be again louder, and we grade our murmurs. A 1 might be just something you hear with a good stethoscope. and as it progresses, you hear it louder and louder. Complications could be dysrhythmias. The blood's not getting where it needs to go. So you're going to start having the heart's going to be a little frustrated and go into a dysrhythmic episode, and possible thrombi and emboli. Think about it. If you're having stenosis and not all the blood is getting through, your body has a chance to coagulate. So because of that, there are a lot of these folks are put on anticoagulation medications. Okay, mitral valve prolapse. It's when one or both of the valve billow into the atrium, okay, during ventricular systole. And it could be caused by rheumatic damage, ischemic heart disease, okay. Commonly affects patients with Marfan Syndrome, which is on the next slide. May be asymptomatic, and it could be asymptomatic for years, but once it starts getting symptomatic, we really have to start listening to it, and we're going to address the problem. Okay, Marfan syndrome. It's really kind of interesting. If you look it up, Google it. Well, actually, I think I have the video or slide on the next. These folks are very long, skinny, okay? It's a connective tissue disease. So we can't just think of connective tissue like in your fingers and your toes and your legs. You have to think of all connective tissue, okay? So lungs, eyes, bones, okay? It's covering everything. So a lot of these patients have problems with their heart and their aorta. Okay, so they're more prone to have aortic aneurysms and mitral valve prolapse. Okay, and like I said, there's a guy. Look how long his foot is. Okay, they're so tall and so thin. Okay, and when I say tall, like 6'6", 6'7", or it's just, it's kind of sad. Okay. Okay, diagnosis, echocardiogram, electrocardiography, and cardiac catheterization. And this is what we're talking about with valvular problems. Okay, we're going to treatment of heart failure, diuretics, ACE inhibitors, vasodilators, possibly some digoxin to help help that heart pump a little bit better. If we have to treat with AFib, DIG, low dose and beta blockers, anticoagulants, and prophylactic antibiotics. Okay, so what can we do for these patients that have valve problems? Okay, well, we can do a percutaneous valve valvuloplasty, which is done in the cath lab, and it's almost similar to what we would do with a balloon for a cardiac cath. Okay, so we put the balloon right right inside the valve, and we blow it up, and hopefully it would help those patients that have stenosis. It gets the rigidity out and opens up that valve. Okay, it's a good choice for patients that can't do open heart surgery. We can do valvuloplasty, which is a reconstruction of the valve, and they're getting better and better at doing this at like the cath lab. Okay, it's no longer needs to be an open procedure. And we can do valve replacement, which is an open procedure. We can do mechanical or biological valves. Now listen, please listen. Mechanical valves need anticoagulation. For the rest of their life, they're going to need it to be anticoagulated. And when I say anticoagulated, it needs to be with Coumadin. Biological valves do not need anticoagulation. They don't need, now biological, that could be from a cadaver, it could be from a cow, it can be from a pig. So, they do not need immunosuppressant medications. Their body is not going to reject these biological valves. Okay, so they don't need that. Not like if somebody gets a kidney or a heart or anything like that. You do not need immunosuppressant, and they do not need anticoagulation. The main difference between the two, mechanical, they need anticoagulation. Mechanical is good for life. It will last all their life. they'll be on anticoagulation for life, but they'll be good for all life. Biological valves are good for about 10 years, 10, 15 years. I'm always going to 10 years. In fact, I think I'm going to Google it just to make sure I'm right. But biological valves they have a lifespan. Both valve replacements are done open surgery. In fact, we had a couple of times where patients were getting cabbages and they also had mitral valve repair at the same time. Okay? So, next slide. Next line. Okay, health promotion, prevention of rheumatic fever or rheumatic heart disease. So we're going to try not to have rheumatic fever. Monitor of heart failure symptoms, cardiac rehabilitation. Remember, we want to get them to start moving. The only patient that we don't want moving is those poor patients that have myocarditis. Okay, aseptic techniques with all invasive procedures. So like whatever we do, we try to be as sterile as possible. Notification of healthcare providers of what's going on. If a patient's having a tooth pulled, we better notify that provider that they need some antibiotics. Anticoagulation teaching. Desired is between 2.5 and 3.5, and it has to be Coumadin. Eliquis, Pradaxa, I'm trying to think some of the other ones. They are not, right now they're not certified to be allowed for prosthetic valves. And even if you listen to the commercials for them, they'll tell you that it's not for valvular prosthetic valves. Okay, and whenever they have to come off of it, we had a patient that had to have a catheterization, and he was on Coumadin because of the fact that you're on anticoagulation. He was on Coumadin because he had a mitral valve replacement. So we gave him vitamin K to decrease that INR. Okay, but at the same time, we put him on heparin. Because remember, heparin has a shorter half-life. So we were able to monitor better and take better control when he was on heparin. So it's kind of interesting. Okay, and that's the end in 37 minutes and 20 seconds. Please, if you have any questions, make notes. And I hope you enjoyed this as much as I did.